Hello, my name is Seth Baum. I'm a preventive cardiologist and clinical lipidologist. I'm a past president of the American Society for Preventive Cardiology and the chief medical officer for Flourish Research. I'm also an adjunct professor of cardiology at the Charles E. Schmidt College of Medicine in Boca Raton, Florida. And I'm here today to discuss the role inflammation plays in atherosclerotic cardiovascular disease, specifically highlighting IL-6 or interleukin-6 as a potential therapeutic target in the future. So first of all, I think we all know that cardiovascular disease remains the leading cause of death in the United States as well as globally. And this highlights the need for additional therapeutic approaches to address this risk. We can look at event rates from clinical trials that demonstrate, even in patients who are very, very well treated, patients in clinical trials are given standard of care, but optimal standard of care. They're tightly controlled, and yet these individuals have very high residual risk of cardiovascular events. Um, Especially, frankly, among patients with polyvascular disease or those who have had recurrent cardiovascular events or those with acute heart failure. We look at inflammation as one of the things that we consider to be contributing significantly to that residual risk. And we have evidence from multiple lines, including human genetic, epidemiologic, mechanistic studies that support a potential therapeutic opportunity by interacting or intervening in the IL-6 pathway to inhibit IL-6 and hopefully reduce the risk of CVD independent of traditional risk factors. If we look at ASCVD and the mechanism of disease, the pathophysiology, we see that IL-6 interacts at multiple levels and in multiple stages in the process. First of all, IL-6 is produced by many cell lines that are integrally involved in ASCVD, such as macrophages, monocytes, endothelial cells, vascular smooth muscle cells, and fibroblasts. IL-6 will increase adhesion of cells to the endothelium and subintimally. IL-6 will increase LDL that is oxidized, increase its uptake by macrophages, leading to more foam cells. We all know that these foam cells are very important in the pathogenesis of plaque. IL-6 thins the fibrous cap, and by thinning the fibrous cap, makes a plaque more vulnerable to a rupture. And IL-6 also increases tissue factor, which increases thrombosis, which we know is a very important part of myocardial infarction and stroke. If we look at a couple of landmark epidemiologic studies of IL-6 and cardiovascular outcomes, we'll see the importance of IL-6. So in 2000, Paul Ridker was the first one to demonstrate the association of IL-6 with cardiovascular events, demonstrating a 38% increase in myocardial infarction for each quartile increase in IL-6 levels. More recently, in 2014, in a large meta-analysis of 29 studies, it was shown that for every one standard deviation increase in IL-6, there was a 25% increased risk of non-fatal MI and fatal cardiovascular disease. The multi-ethnic study of atherosclerosis, or MESA, demonstrated something very, very interesting when it evaluated both IL-6 and hs-CRP. And it looked at IL-6 and hs-CRP levels as being high or low. And what it found was when there is a discordance between the two, IL-6 drove the risk of cardiovascular events. What they showed was when IL-6 levels were high, regardless of CRP levels, so CRP levels low or high, risk was elevated. The same did not hold true for CRP. In other words, when CRP was elevated, it wasn't true that regardless of IL-6 levels, the risk was elevated. It was only when IL-6 levels were elevated was the risk of atherosclerotic cardiovascular events elevated. Why would that be? Well, it turns out that IL-6 is an important proximal mediator of inflammation. So it's involved in the pathways of inflammation, in causing things to happen down these inflammatory pathways, while hs-CRP is a marker, and it's a late marker of inflammation. So it is not a driver of inflammation. When we look at genetic studies, this confirms exactly what I'm saying. In other words, in our Mendelian randomization studies, CRP is not causal when it comes to inflammation, rather is not causal when it comes to cardiovascular events, while IL-6 is causal. So in sum, there are several key takeaways that we should focus on. First, we need to recognize that cardiovascular disease remains the leading cause of death in the United States and abroad. And we also need to emphasize that there is accumulating evidence highlighting inflammation as a key driver of CVD. And not only is inflammation a key driver of CVD, but it's a great opportunity for us to reduce residual risk of CVD when we treat our patients appropriately with our current lipid-lowering therapeutics and other therapeutics to decrease cardiovascular risk factors. There's converging evidence from human genetic, epidemiologic, and mechanistic studies that support a therapeutic potential of IL-6 pathway inhibition to reduce the risk of CVD that is independent of traditional risk factors. And we have to emphasize that recent studies have found IL-6 to be more strongly associated with atherosclerosis, heart failure, fatal outcomes, aortic valve calcification when compared to hs-CRP, and really may be a better marker in cardiovascular outcomes trials. And this is something that we are looking at in current cardiovascular outcomes trials, and we'll have much more information in the not too distant future. Thank you very much.